Good morning, everyone, and welcome to our exploration of Chapter 1 from your Medical Statistics textbook. I'm Dr. Brown, and today we're diving into uses and abuses of medical statistics. Before we begin, let me tell you why this chapter is so important. Whether you realize it or not, you encounter statistics every single day in healthcare, from reading research papers to interpreting diagnostic tests to making treatment decisions. By the end of today's lecture, you'll understand why statistical literacy isn't optional for healthcare professionals. It is essential. We'll be covering about 45 minutes of material, and I'll be pausing periodically to let key concepts sink in. I encourage you to take notes. And remember, if something doesn't make sense the first time, you can always rewind and watch again. That is one of the great benefits of online learning. Let's get started by looking at our roadmap for today. Here we are at Chapter 1, Uses and Abuses of Medical Statistics. Notice the title carefully. We're going to talk about both the proper uses and the common abuses of statistics in medicine. Our learning objectives for today are as follows. First, we want to understand why statistics are absolutely essential in medical research. Second, we need to recognize common statistical misconceptions, and trust me, they're everywhere. Third, we'll learn how statisticians can actually improve research quality when involved early in the process. And finally, we'll appreciate why good study design is more important than fancy statistical analysis. All of these lectures are from the 5th edition of the textbook by Campbell and Machin. These are internationally recognized experts in medical statistics, so we are learning for the best. Now, before we dive in, I want you to think about this question. How often do you think you encounter statistics in your professional reading or clinical practice? Keep that in mind as we go through today's material. Let's look at our roadmap for this chapter. We have 4 main sections, and they build logically on each other. We start with the introduction, which answers the fundamental question, why do medical professionals need statistical literacy? Then we move to why use statistics? This section will show you why statistics aren't just academic exercises, but practical necessities in medicine. Our third section has my favorite title. Statistics is about common sense and good design. This is where we'll learn that statistics isn't about making simple things complicated. It is about dealing honestly with complexity that already exists in medical research. Finally, we'll explore how a statistician can help throughout the research process, not just at the end when it's time to analyze data. Now, here are the key messages that I want you to remember throughout today's lecture. The key message. Statistics is not just about calculations. It is about sound, scientific reasoning, proper study design, and avoiding common pitfalls that can lead to incorrect conclusions. This is crucial because many people think statistics is just about plugging numbers into formulas. But as we will see today, the real value of statistics is in thinking clearly about uncertainty, variability, and causation. Keep this in mind as we go through each section. Now let's dive into our first main section, the introduction, and I'm going to start with some numbers that might surprise you. Look at these statistics about statistical usage in medical journals. The British Medical Journal, 64% of articles use statistical analysis. The New England Journal of Medicine, this is the most prestigious medical journal in the world, 95% of articles contain inferential statistics. 95%. So what does this mean for you as a healthcare professional? It means that if you're reading medical literature, and you should be, 9 out of 10 articles you encounter will contain statistical analysis. You simply cannot be an informed healthcare professional without understanding statistics. This isn't just an academic concern. We're living in the era of evidence-based medicine, or EBM. The whole philosophy of EBM is that we make clinical decisions based on the best available evidence, not just tradition or a gut feeling or intuition. But here's the thing. That evidence comes to us through statistical analysis. Think about it this way. When a new drug comes to market, how do we know it works? When clinical guidelines recommend a particular treatment, what's that recommendation on? When you read that a diagnostic test has 95% accuracy, what does that actually mean? All of these questions require statistical understanding. So here's the reality check. If you can't evaluate the statistics in a research paper, you can't properly evaluate the research itself. And if you can't evaluate the research, how can you make truly informed decisions about your patient care? This creates a great professional responsibility. As healthcare providers, we have an obligation to stay current with research and to make evidence-based decisions. That's impossible without statistical literacy. So I want you to pause here and think about your own experience. When you read medical literature, do you skip over the statistics section? Do you just trust the author's conclusions without understanding how you reach them? If so, don't worry. You are about to change that. This brings us to our second major question. Why use statistics at all? And the answer lies in a fundamental truth about biology and medicine. Biological variation is everywhere and it's unavoidable. Let me give you a concrete example. So look at this study about blood pressure in children by O'Sullivan and colleagues. They found that normal healthy children had systolic blood pressure below 130 milligrams Hg when resting. But during the school day, it rose to 160 milligrams Hg. And at night, it dropped back down below 130 milligrams Hg. This is the same child on the same day with the blood pressure varying by 30 milligrams. Now, imagine you're trying to define normal blood pressure in children. How do you account for this variation? Well, this is fundamentally different from physics or chemistry. If I drop a ball, I can predict exactly where it will land using physics equations. If I put blue litmus paper in acid, it will turn red 100% of the time. But if I give an aspirin to 100 people with headaches, what happens? Some will feel better in 20 minutes, some in 2 hours, and some will not feel better at all, and some may get an upset stomach instead. This is the challenge of biological science. We are dealing with living systems that are inherently variable. Statistics give us tools to find meaningful patterns despite this variability. Here's another way to think about it. In physics, if I get an unexpected result, I look for experimental error. In biology and medicine, if I get an unexpected result, it might be an error or it might be a real biological variation. Statistics helps us tell the difference. And this isn't just about research. This affects clinical practice every day. Why do some patients respond to a medication while others do not? Why do lab values have reference ranges instead of a single number? Why do we need to repeat tests sometimes? All of this comes back to biological variation, and statistics helps us understand and work with that variation. I want you to think about the examples from your own experience where you've seen this kind of biological variation. Maybe patients responding differently to the same treatment, or lab values that seem to fluctuate without explanation. Keep those examples in mind as we continue. This is a great place to pause and let these concepts sink in. When you're ready, you can continue with the detailed example that shows how these principles apply to real medical research. Now, before we go further, I want to address something you've probably been hearing about: data science and AI in medicine. You might be wondering, with all this talk about machine learning diagnosing diseases and AI analyzing medical images, do we still need traditional statistics? Well, the answer is absolutely yes, and here is why. Traditional statistics and data science are complementary approaches, not competing ones. Let me say this again. Traditional statistics and data science are complementary approaches, not competing ones. Data science is fantastic at finding patterns in massive data sets. Wow, this would have been so much easier in graduate school if I had AI to assist me in finding patterns in massive data sets. Machine learning can identify subtle features in medical images that humans might miss. These are powerful tools. But here's what data science often lacks: the theoretical framework for understanding uncertainty, the principles of good experimental design, and the methods for establishing causation rather than just correlation. So let me give you a concrete example of this. During the COVID-19 pandemic, dozens of machine learning models were developed to predict which patients would have severe diseases. Most of the models fail when deployed in real hospitals. Well, why? Because they lack the statistical rigor to account for changing conditions, different populations, and confounding variables. Statistics provides the conceptual foundation that makes data science reliable and interpretable. When we understand principles like confounding, bias, and uncertainty quantification, we can build better models and interpret their results more carefully. So as we go through traditional statistical concepts, remember, these are not outdated ideas. They are the foundation that makes modern data science work properly in medical settings. Now I want to walk you through a detailed example that shows how these statistical principles work in practice. This is the story of coffee and cancer, and it's a perfect illustration of why association doesn't equal causation. In 2016, a working group of 23 scientists from 10 countries met to review evidence about coffee consumption and cancer risk. They analyzed over 1,000 studies. That's a huge amount of research, and here is what they found. For bladder cancer specifically, there was no consistent evidence that drinking coffee increased cancer risk. In fact, for most cancers, coffee drinkers either had the same risk as non-coffee drinkers or actually had a lower risk. But here's the interesting part, and this is where statistics becomes crucial. Early studies had suggested that coffee might increase bladder cancer risk. So what changed? Better statistical analysis that accounted for confounding variables. So look at this diagram. We have coffee consumption as our exposure, what we're studying. We have bladder cancer as our outcome, what we're measuring. But notice the third element, confounding factors, specifically tobacco and alcohol consumption. So here's the key insight. Heavy coffee drinkers were much more likely to smoke cigarettes and drink alcohol. And we know that tobacco and alcohol are strongly associated with bladder cancer. So the question becomes, is it the coffee causing cancer, or is it the smoking and drinking that heavy coffee drinkers do? Which one is it? Well, this is a classic confounding situation. A confounding variable is something that is associated both with the exposure you're studying and the outcome you're measuring. So it can make it look like there's a causal relationship when there isn't one. Think about it logically. Imagine two groups, heavy coffee drinkers and non-coffee drinkers. If the coffee drinkers smoke more and drink more alcohol, and if smoking and alcohol cause cancer, then the coffee drinkers will have higher cancer rates. But it's not because of the coffee. It's because of the smoking and drinking. This is why observational studies, studies where we just observe what people do rather than assigning treatments, can identify associations. But establishing causation requires much more careful analysis. The lesson here is profound. Correlation does not equal causation. This phrase is thrown around a lot, but understanding confounding variables helps you to see why it is true and what to do about it. I want you to pause here and think of other potential confounding variables in health research. What about socioeconomic status, age, geographic location, healthcare access? These variables can confound almost any health study, which is why statistical analysis is so important. This brings us to what I consider the most important conceptual point in this entire chapter. Look at this quote carefully. A well-designed study, poorly analyzed, can be rescued by a reanalysis, but a poorly designed study is beyond the redemption of even sophisticated statistical manipulation. So let me say it this way. You can fix bad analysis, but you can't fix bad design. This is crucial to understand. Statistics is not magic. No amount of sophisticated statistical analysis can salvage a study that was poorly designed from the beginning. If you study the wrong population or forget to include a control group or fail to account for important confounding variables, no statistical technique can fix those problems after the fact. This is why the chapter is titled Statistics is about Common Sense and Good Design. Good statistics starts with good thinking about the research question, the study population, the measurements, and the potential sources of bias. So let me give you a historical example that illustrates this perfectly. The link between smoking and lung cancer wasn't obvious to doctors in the 1940s and 50s. In fact, and I can attest to this, I worked in a hospital during the 60s and 70s. Many doctors smoked. The connection was discovered through careful statistical analysis of well-designed studies by researchers like Richard Dahl and Austin Bradford Hill. But here's the key. They didn't just crunch the numbers. They carefully designed studies that could distinguish between correlation and causation. They followed people over time. They compared smokers to non-smokers who were similar in other ways. They looked for dose-response relationships. The statistical analysis was important, but it was the careful study design that made the analysis meaningful. This principle applies to every level of medical research, from large clinical trials to small laboratory studies. So before you collect any data, before you run any statistical test, you need to think carefully about what you're trying to learn and how to design a study that can actually answer that question. This has immediate practical implications for you. When you're reading research papers, don't just look at the statistical results. Look at the methods section. Ask yourself, was the study designed in a way that could actually answer the research question? Are there obvious confounding variables that weren't considered? Is the study population relevant to your patients? Now let's look at how these statistical principles affect something you encounter every day in clinical practice, diagnostic test. And I'm going to share some numbers that might surprise you. So the UK National Health Service invites all women aged 50 to 70 for breast cancer screening every 3 years. Here's what the data shows. If 100 women have breast screening, 96 will have normal results and 4 will need more tests. Of those 4 who need more tests, only 1 will actually have cancer detected. Think about what this means. If a woman gets a positive screening result, meaning she needs more tests, there's actually a 75% chance she doesn't have cancer. 3 out of 4 positive screening results are false positives. This might seem counterintuitive, but illustrates a fundamental principle. A positive test does not mean disease is present. A negative test does not mean disease is absent. There are always false positives and false negatives. But here's what's more striking. Even among medical experts, there can be significant disagreement about test results. So look at the study by Elmore and colleagues about melanoma diagnosis. When pathologists, medical doctors who specialize in diagnosing diseases from tissue samples, looked at melanotic skin lesions, only 83% were accurate when compared to an expert panel. But here's the really surprising part. When an independent expert panel looked at the same cases, only 58% would give the same diagnosis as the original pathologist. In 8% of the cases, they would give a worse prognosis. And in 9% of the cases, they would underestimate the severity. So these are experts looking at the same tissue samples and reaching different conclusions. This isn't because anyone is incompetent. It's because there is inherent variability in medical diagnosis, even at the expert level. Well, what does this mean for clinical practice? First, it means we need to really understand uncertainty and communicate it appropriately to patients. When we say a test is 95% accurate, patients need to understand what that really means. Secondly, it means we need statistical thinking to interpret test results in context. The probability that a positive test indicates disease depends not just on the test characteristics, but also on how common the disease is in the population being tested. This is where concepts like positive predictive value and negative predictive value become crucial. These are statistical measures that tell us what a test result actually means for an individual patient. So think about how this applies to your practice. When you order a test, you're essentially making a statistical calculation, weighing the probability of a disease against the risk and benefits of testing. Understanding these statistical principles makes you a better clinician. So far, we've covered a lot of conceptual ground. So let's take a moment to process these ideas about study design and diagnostic uncertainty. When you're ready, you can move on to the practical question. How can working with a statistician improve medical research? This brings us to our final main section, how a statistician can help. And the key message here is seek statistical advice at an early stage of investigation, not just for analysis after data collection. Most people think of statisticians only when it's time to analyze data, but the biggest value comes much earlier in the research process. Let me show you why with a concrete example. Suppose you want to study whether diabetic patients have a higher blood pressure than healthy subjects. You suspect there might be a 5 millimeter of mercury difference, and you know from previous research that the standard deviation is about 10. How many subjects do you need to detect this difference? This is called a sample size calculation, and it's one of the most important things a statistician can help with. Using statistical formulas, we can calculate that you need 64 subjects in each group, so 128 total subjects, to have an 80% chance of detecting a true 5 millimeter of mercury difference. Now, what does 80% chance mean? It means that if you run the study with 128 subjects, and there really is a 5 millimeter of mercury difference between the groups, you have an 80% probability of detecting it as statistically significant. Put another way, there's a 20% chance your study will fail to detect a real difference. This is incredibly valuable information to have before you start your study. It helps you plan your timeline, your budget, your recruitment strategy. It also helps you decide whether the study is worth doing at all. So imagine if you had planned to recruit only 30 subjects total. A statistical calculation would show that you'd have less than a 20% chance of detecting the difference you're looking for. That means an 80% chance of failure. Even if your hypothesis is correct, you'd be much better off not doing the study at all or redesigning it to be more efficient. This example also illustrates another key point. You can increase your probability of success by increasing your sample size, but there are practical limits. If detecting a 5 millimeter mercury difference required 1,000 subjects, you might decide the effect isn't clinically important enough to justify such a large study. There are the kinds of strategic decisions that statistical consultation can help you with, but only if you're involved with a statistician in the planning phase. So this is important. This is why early statistical consultation is so important. It's much cheaper to get the design right from the beginning than to repeat a failed study, and it's more ethical too. There's no point in enrolling patients in a study that's doomed to fail because of an inadequate sample size. Statistical consultation goes far beyond sample size calculations. Let me give you some other areas where statisticians add value throughout the research process. So first of all, questionnaire design. If you're doing survey research, the way you phrase questions and the structure response options can dramatically affect your results. A statistician can help ensure that your questions can be easily coded for computer analysis, that you avoid leading or ambiguous questions, and that you plan for missing data and non-response. They can also help you pilot tests before your questionnaire and modify it before you launch your full study. This might seem like a small detail, but poorly designed questionnaires will ruin an otherwise well-planned study. Second, study design considerations. A statistician can advise on randomization methods to ensure fair treatment allocation, blinding strategies to minimize bias, and control group selection to choose appropriate comparisons. Third, laboratory experiments. Even if you're not working with human subjects, statistical principles still apply. A statistician can help with quality control of routine measurements, assessment of within and between observation of variation, and decisions about experimental unit assignment. But here's one of my favorite examples of why design matters: paired versus unpaired data. Suppose you want to study blood pressure changes when patients move from sitting to lying down. You could measure blood pressure in 50 seated patients and 50 different lying patients, and then compare the groups. Or you could measure blood pressure in the same 50, both seated and lying down. These two approaches require completely different statistical analysis. In the first case, you're comparing two independent groups. In the second case, you're analyzing paired data, the same person measured twice. The paired design is almost always more powerful because it controls for individual differences. The important statistic isn't the average blood pressure in each position, it's the change in blood pressure within each position, each person. This might seem obvious when I explain it this way, but I've seen numerous studies where researchers didn't think about this distinction during the design phase and end up with less powerful analysis than they could have had. So the lesson here is that statistical thinking affects every aspect of study design, not just the final analysis. That's why early consultation is so valuable. Let's wrap up by reviewing the key takeaways from today's lecture. These are the concepts I want you to remember and apply in your professional practice. First, statistical literacy is mandatory for modern healthcare professionals. This no longer is optional. With 95% of major medical journals using statistical analysis, you cannot be an uninformed healthcare provider. You must be an informed healthcare provider and understand the statistics. Second, good design trumps sophisticated analysis every time. You cannot fix a poorly designed study with clever statistics, but you can rescue a well-designed study with proper reanalysis. This means thinking statistically from the very beginning of any research project. Third, early statistical consultation prevents costly mistakes. Most of the value a statistician provides comes in the planning phase, not the analysis phase. Sample size calculations, study design decisions, and data collection strategies are all more important than the final statistical test. Fourth, biological variation is inherent and unavoidable. Unlike physical science, where repeated experiments give identical results, biological systems are inherently variable. Statistics gives us the tools to find meaningful patterns despite this variability. Now, let me share some common pitfalls to avoid. Don't confuse association with causation. Just because two things are correlated doesn't mean one causes the other. Don't ignore confounding variables. Always ask what other factors might explain an observed association. Don't use inadequate sample size. Underpowered studies waste resources and are unethical. And don't try to fix poor study design with analysis. It simply can't be done. But here's the most important takeaway of all. Statistics is fundamentally about good scientific thinking. It's about using data to make informed decisions while acknowledging uncertainty and variability. When you read a research paper, you're not just reading the results. You're reading and evaluating the quality of the scientific reasoning that led to those results. When you interpret a diagnostic test, you're not just reading a number. You're weighing probabilities and uncertainties. When you make treatment recommendations, you're not just following guidelines. You're applying statistical evidence to individual patients. This is what evidence-based medicine really means, using statistical thinking to bridge the gap between research evidence and clinical practice. I'll leave you with this quote from the textbook. Medical statistics should be consulted early in the planning of a study, as they can contribute in a variety of ways and not just once all the data has been collected. Remember this principle whether you're conducting research, reading research, or applying research findings to patient care. Statistical thinking isn't just about the numbers. It's about clear reasoning in the face of uncertainty. This concludes our exploration of Chapter 1, Uses and Abuses of Medical Statistics. We've covered why statistics are essential in medicine, how biological variation makes statistical thinking necessary, the importance of good study design, and how statisticians can improve research quality throughout the entire research process. As you continue through this course, remember that each statistical method we learn serves a purpose, helping us think clearly about uncertainty, variability, and causation in medical research and clinical practice. For your next steps, I recommend reviewing the key concepts we covered today, especially the examples of confounding variables and the principles of good study design. These concepts will be foundational for everything else we study and cover in this course. If you have questions about the material, don't hesitate to reach out. Remember, statistics can seem intimidating at first, but it's really about developing clear thinking skills that will make you a better healthcare professional. Thanks for watching, and I'll see you in our next lecture, where we'll dive deeper into the practical application of these concepts.